Hello, I'm Professor Alain. I'm head of medical intensive care unit at La Pitié-Salpêtrière, Sorbonne University Hospital in Paris, France. And it's a privilege for me to talk to you about VA ECMO for cardiogenic shock patients. First, this is my disclosure slide. So, veno-arterial ECMO can support both the heart and the lungs. There may be specific indications and time to discuss this type of assistance in severe cardiogenic shock patients. And it's mainly for those patients who developed a refractory cardiogenic shock, and maybe those who have a low cardiac output, and very simply at Doppler echocardiography, those who have aortic VTI below 7 to 8 centimeter. This is the new SKY classification staging for cardiogenic shock from A to E. And we will discuss here the classic to the extreme severity of ECMO. And for sure, those who have extreme might be the first to receive the technique. So we might discuss further the accepted indications and the results in these patients. And for sure, the first in terms of numbers is those patients who got cardiogenic shock in the setting of acute myocardial infarction. And in the literature for now, it's mainly patients who have developed extreme cardiogenic shock who received ECMO. This is an old study now, but which showed that the implementation of an ECMO program might be able to significantly improve the outcome of severe cardiogenic shock patients. This is another more recent series here by our group of 138 patients who all developed refractory cardiogenic shock. And we got almost 50% survivors here, which was much better than 10 years ago. And the second good news about that study, it was for those who survived, almost 2/3 of them were, it was possible to win them successfully for the machine without the need for a complex heart surgery of a long-term VAD following the weaning or heart transplantation. Second population who might benefit also for this type of strategies, those who have dilated cardiomyopathy, would develop refractory cardiogenic shock. Also a study here by our group showing that it's possible to bridge these patients to heart transplantation with VA ECMO. Fulminant myocarditis is also one of the best indications, probably the best in terms of outcome. And in that study, the long-term survival was close to 70%. We are talking about young patients. Most of them actually might recover for those who do not have too severe disease initially. And those results are actually very encouraging. Cardiac surgery, also data coming from recent retrospective series here, very large here, collaborative group showing that now it's close to 1% of the patients following heart surgery who might receive VA ECMO for cardiogenic shock. And looking at here in red, the survival rate, it clearly has improved over the last decade. And now close to 50% of those patients might survive. There was a scoring system which was developed here showing that elderly patients, female, those who have severe shock with high lactate, or those who have developed stroke might have dismal prognosis. But there was clearly here also good news from that study. Heart transplant, for those centers doing heart transplant, ECMO also completely changed the outcome of the patients. These are data here of our center, which does close to 100 heart transplants per year. And it was showed that it's only those patients who got ECMO post-transplant because of severe cardiac dysfunction post-heart transplant who got worse prognosis. And it was possible to bridge patients with ECMO to transplantation with very good results, actually. So this is the classical, the so-called accepted indications. And now we might discuss what might be the future of ECMO in severe cardiogenic shock patients, the emerging indications. Going back to acute MI patients, we might decide to insert ECMO early on in the course of the disease in patients who do not have yet refractory cardiogenic shock. looking back here to the SKY staging, this might be patients who have reached the class C, not the class E, which probably may have a more dismal prognosis. And when looking here at Holger Tille culprit shock trial, and when looking at the reason for death, those patients who died in that study most frequently died of refractory cardiogenic shock. So it is possible, as was here underlined by Dr. Hockman in the editor of New England of the culprit trial, that ECMO may be able to save life if ECMO is inserted early on in the course of the disease. And she also underlined that ECMO should be submitted to the same randomized clinical trial methodology now for cardiogenic shock. And there may be here a room for improvement in the outcome of these patients should ECMO be initiated early in the course of the disease. And in Europe, there is now 3 studies testing this strategy in patients who have cardiogenic shock, but we did not develop yet refractory cardiogenic shock with multiple organ failure. So we might have the results of those studies in 2 or 3 years from now. Other potential indication, patients would develop catastrophic pulmonary embolism. These patients also have a very poor prognosis. Those patients might have developed cardiac arrest or pre-arrest. And this is a series here published a couple of years ago in Care showing that it's probably possible to salvage up to 50% of those patients, including patients who have developed severe dysfunction and cardiac arrest before getting ECMO. So the potential use of ECMO in severe cardiogenic shock in the context of PE might be just to salvage patients, might be a bridge to embolectomy, whether it is surgical or catheter-based embolectomy, or it might be used as single standalone strategy. This is also here room for more research in that field. Another group of patients also who might benefit from VA ECMO is those who have developed cardiac arrest, whether it is immediate cardiac arrest or those who have developed cardiac arrest and who develop cardiogenic shock following a recovery of cardiac arrest. The question here to define the population of interest is quite tricky, because if ECMO is inserted in the wrong patients, the outcome of the patients might be quite dismal. So we need to define those who might benefit the most. Clearly, there is an age limit. Is it 50, 60? This should be also clearly now analyzed by registries or studies on site. It's very important that it's a witness cardiac arrest with bystander CPR, with a no flow limited to less than 5 minutes. I would say maybe 0 minute if possible. Cardiac arrest should be of presumed cardiac origin, and it's better to focus on patients with initial shock algorithm. Those who have non-shock algorithm have a mortality which is close to 100%. And maybe the most important point here is to stick to patients who have total low flow time less than 1 hour. And we say 1 hour, probably it's better to write in guidelines 50 minutes to get the best results possible. Last population of patients, there is a population of patients who have septic shock and who might develop severe and sometimes refractory cardiac failure with low ejection fraction, low cardiac output in the context of septic shock. And these are very recent data we also gathered with friends in an international collaborative series here. This is a series of more than 80 severe septic shock patients who did develop these most dismal forms of septic shock with cardiovascular failure. And we used an historical cohort of patients who had septic shock, and we also developed this kind of refractory cardiovascular failure. Those patients were mostly enrolled in the sepsis-PAM cohort of patients with a randomized study conducted in France, testing two levels of mean arterial pressure in septic shock, and we were able to show that the survival rate with ECMO was strikingly better than in those patients who did not receive ECMO. This might be also a new indication for the coming years. So in conclusion, there is clearly room here for ECMO in patients with refractory cardiogenic shock. ECMO is now cheaper, very easy to set up, versatile, more adapted to cardiogenic shock than other types of machines, especially the big machines. We also need to build networks of hospitals here to refer patients. We need a mobile cardiac ECMO team also to retrieve the most severe patients on ECMO to the heart center. And we need to have more evidence, and we definitely need to get the results of these big trials in MI patients. And one of these trials is the ANCHOR trial we'll coordinate here in France. Thank you so much for your listening. Thank you.